Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be covering pediatrics, but to be more specific, I'm going to be going over dehydration and diarrhea. So before we get started, you know what I'm about to ask you. If you haven't done so already, please help support me, help support this channel by liking this video. You know you're going to love it. Like this video now so you don't forget. Subscribe to this channel if you haven't done so already. And don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. All right, guys, so let's start with dehydration. Look at what it says. And guess what? I remember the pen this time. When it comes to dehydration, you know what dehydration is. I don't have to explain that. Look at what it says. It says weight is the most important determinant of the percent of total body fluid loss in infants and younger children. Guess what? Same for adults. I said this to you guys a million times. When you want to know about the patient's fluid status, it's not going to be INO. It's not going to be skin turgor. It's going to be this right here. Weight. You want to take the patient's weight. Other predictors of fluid loss include changing level of consciousness, them being irritable or lethargic, altered response to stimuli, decreased skin elasticity or turgor, that skin turgor being more than 3 seconds, prolonged capillary refill being more than 2 seconds, increased heart rate, sunken eyes, and fontanelle. All of those will give you an idea if that patient's experiencing fluid loss, if they're experiencing dehydration. But the most important determinant is going to be that patient's weight. Clinical signs provide clues to the extent of dehydration. Okay, how bad is that dehydration? The earliest detectable sign is usually tachycardia. Then after the tachycardia, you may see dry skin, dry mucous membranes, you may see sunken fontanelle, you may see signs of circulatory failure, such as coolness. When you touch that patient's skin, it's supposed to be nice and warm, not cool or cold, mottling of the extremities, a loss of skin elasticity, and prolonged capillary filling time. But the first thing that you may notice or you should notice is increased heart rate, tachycardia. Why is that? Well, think about it. The fluid that's in the vascular space, that is what's supposed to be going to the tissues to perfuse those tissues. What does that word perfusion mean? That means to feed, right? To perfuse those tissues. That means if the patient's dehydration, if the patient is dehydrated, they have decreased fluid in the vascular space. That means decreased perfusion. What's one of the first things we're going to see happen? The heart rate's going to speed up. Why? That heart's trying to compensate. It's trying to push out fluid that the patient doesn't have, but it's going to try. That's why we see that tachycardia. That is important to know. Okay? Tachycardia, that is one of the first signs that we're going to see in that patient that's dehydrated. All right, let's talk about diagnostic evaluations. How do we diagnose? How is a patient diagnosed? We don't diagnose them, but how are they diagnosed? What are we looking at? Now, all of these big words, I'm not going to read all of that, but all of this is to say that we're going to see the H and H increase. Whenever you see that H and H elevated, that tells you dehydration. My coffee's done. Okay, the H and H is going to be increased. BUN creatinine is going to be increased. Why? Because the kidney's suffering. Whenever you're dehydrated, the kidneys are going to suffer. And urine output is going to be what? Decreased. If you're dehydrated, you don't have enough fluid in the vascular space. You don't have enough fluid to perfuse your tissues and organs. Your body's going to try to save itself no matter what. You're going to see that heart rate go up because it's trying to increase the perfusion, right? But you're going to see the urine output go down. Why? Kidneys starting to shut down, and the little bit of fluid that you do have is trying to shunt it to the most vital organs, such as your brain, right? So you're going to see those urine output go down, heart rate go up, H and H up, BUN and creatinine up. That is very important to know. Let's keep going. One of the most important determinants of the extent of dehydration is what? Body weight. So again, you're going to take the patient's weight. Important clinical manifestations include changing sensorium. Again, this is the second time we're seeing this, guys. Then being irritable, lethargic, decreased response to stimuli. We can see changes in their skin, such as decreased elasticity or turgor, prolonged capillary refill time, taking more than 2 seconds, increased heart rate. That's the tachycardia, sunken eyes, and in infants, sunken fontanelle. The sunken eyes, sunken fontanelle, and where's the tachycardia? I don't see it here, but oh, here it is. Those are the examples you guys will see most often for testing purposes, but I don't write your exam, so make sure you know all of them. Moving on, therapeutic management. Medical management is directing at correcting the fluid imbalance and treating the underlying cause. So we're going to replace the fluids that the patient has lost, but at the same time, we want to correct whatever's causing this dehydration. When the child's alert, awake, and not in danger, correction of dehydration can be attempted with oral fluid administration. Think about it. If that patient is not awake, they're not alert, why would you try to replace the fluids orally? You want that patient to aspirate. Now patient's got pneumonia. Now patient has all these respiratory issues because we gave fluids to a patient that was not even alert and awake. So it's very important. Make sure that patient is alert and awake before we start rehydrating them orally. Oral rehydration therapy is effective for treating mild to moderate dehydration in children. Now, let's look at some goals. What are the patient outcomes we want to see in the patient who is experiencing fluid volume deficit, also known as what? Dehydration. Moist mucous membranes instead of dry mucous membranes. Sodium and potassium within normal limits. Let's talk about this. So another thing that we see, guys, when the patient is dehydrated, we tend to see that sodium and we tend to see that potassium increase. Why? Think about it, guys. There are no fluids. So we're going to see it increase, just like if they had too much fluid, it would be dilutional and it would be decreased. So you got to watch out for that. Voiding more than 1 ml per kilogram per hour. Them losing, excuse me. I just had a brain fart, guys. So a goal is them avoiding more than 1 milliliter per kilogram per hour. And here's why that's important to us. Them voiding this normal amount lets us know the kidneys aren't in trouble. When are the kidneys in trouble? One of the biggest reasons that kidney would be in trouble would be dehydration. So we want to see that patient voiding at least 1 milliliter per kilogram per hour. Now, if we were talking about adults, we just say 30 mLs per hour. But since we're talking about kids, it's what? 1 ml per kilogram per hour, at least. Capillary refill, 2 seconds or less. It should not take forever, right? For when you check the capillary refill for that area to become nice and pink again. Skin turgor to be brisk. We don't want that skin turgor the time for the skin turgor increased. We don't want to see that skin tenting because that tells us the patient's dehydrated. Fluid intake and output balance. What goes in is coming out. All of these are goals that we want to see. Parental fluid therapy. Parental fluid therapy is initiated when the child is unable to ingest sufficient amounts of fluid and electrolytes to meet the ongoing daily physiological losses, replace previous deficits, and replace ongoing abnormal losses. All of these are reasons why we would skip the oral rehydration and give them fluids parentally. Or we may try to give them orally as much as we can, but that's not sufficient, so they'll have to get the fluids parentally as well. All right, let's move on to diarrhea. You guys know what diarrhea is. I'm not gonna go over that, but let's talk about the types of diarrhea for a moment. Acute diarrhea. Remember, when you see that word acute, that means something comes on immediately. Acute diarrhea is self-limited, so it'll go away on its own. It's supposed to be, all right? It's self-limited, 14 days duration or less, and it subsides. It goes away without specific treatment. Chronic diarrhea is an increase in stool frequency and increased water content with duration of more than 14 days. So acute diarrhea, 2 weeks or less. Chronic, more than 2 weeks. Look at this table, infectious causes of acute diarrhea. See if I can make this a little smaller so everything will fit for you. Okay. So the first one, rotavirus. Look at what it says about rotavirus. Most common cause of diarrhea in children less than 5 years old and infants 6 to 12 months old. And important cause of nosocomial infections. So rotavirus is an important cause of infection that the patient will get while in your facility. They didn't get it from home, in your facility. Next, bacterial, E. coli. Foodborne, I don't know why I didn't have a star next to that, but you need to know that. Foodborne pathogen, traveler's diarrhea, and antibiotics can make it worse. Avoid anti-motility agents and opioids. Anti-motility agents and opioids both do what? Slow down movement of the GI tract. Usually transmitted person to person, but may transmit via uncooked, I need to underline that. That's important for you guys to know. Uncooked meats or poultry. That's important to know. In children, related to pets, such as dogs, cats, hamsters. Antibiotics, not recommended in uncomplicated cases. Remember, guys, if you go back up here, what does it say? Antibiotics may make it worse. All right, moving on. Salmonella. What's important to know about salmonella? This viral agent. Wait, no, salmonella is not a virus. Salmonella. No, salmonella is not a virus. It's a bacteria. Just joking. It's not viral. Okay, salmonella. Look at the comments. Ingestion of foods and water contaminated with human feces is most common mode of transmission. So what are you thinking? Somebody who went to the bathroom did not wash their hands and then prepared your food. Nasty. I know. All right. Make sure you know that. Clostridium perfringens. I know I butchered that, but you see it. Look at the comments for this one. Make sure you know it. Transmitted by contaminated food products, most often, again, meat and poultry. Oral rehydration is usually enough for it to pass. Again, antibiotics serve no purpose and should not be used because, matter of fact, you give them antibiotics, it may make it worse. Let's go over the etiology. Most pathogens that cause diarrhea are spread by the fecal oral route. Let me make this bigger for you guys again. By the fecal oral route through contaminated food or water, or they're spread from person to person where there's close contact, such as daycare centers. Rotavirus, again, we saw this on the table, and now we're seeing it again in the text. Rotavirus is the most important cause of serious gastroenteritis among children. Salmonella, Campylobacter, Yersinia, and Shigella organisms are the most frequently isolated bacterial pathogens in the US. Antibiotic administration is frequently associated with diarrhea. Why? Because antibiotics alter the normal intestinal flora, resulting in an overgrowth of other bacteria. This is what's known as superinfections. C. diff is the most common bacterial overgrowth, and that happens when the patient gets too many antibiotics, or they get antibiotics when they shouldn't have gotten them. So now patients got a superinfection. C. diff is one of them that can happen. Pathophysiology. The most serious and immediate physiologic disturbances associated with a severe diarrheal disease are dehydration, because guess what? They're losing fluids. By the way, guys, base comes out the butt. So patient has diarrhea long enough, that can throw them into a metabolic acidic state, base out the butt. Okay? Anyway, what can happen? Dehydration, acid-base balance with what? Ding, 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 acidosis. Why? Because base comes out the butt. And shock that occurs when dehydration progresses to the point that circulatory status is seriously impaired. Think about it. Patient has diarrhea. They're losing fluids through their stool. They may lose fluids to the point that they're not what? Dehydrated. Their organs are not being perfused. What can this cause? Shock. Diagnostic evaluation. The history should include questions about recent travel. Exposure to untreated drinking water or untreated washing water resources. Contact with animals, birds, ding, 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 daycare center attendance. Recent treatment with antibiotics, because we know those antibiotics can cause superinfections. or recent dietary changes. Is it something they ate that gave them the diarrhea? So as a nurse, you have to be an investigator and ask lots of questions. I want you guys to notice something, and I keep preaching this to you. I know one of these days you're going to listen to me. Whenever you see the author of a textbook, I don't care what textbook you're using, whenever you notice the author of a textbook is presenting the same information over and over and over again, except they're presenting it in different ways, that means it's important to know. Have you guys noticed the same information that we're going over on this page? We either saw it in the table that we just covered, or we saw it in the page before, and now they're repeating themselves. They're doing it because this is important. Most likely, you're going to see this as a test question somewhere in your academic career. All right, let's keep going. Watery, explosive stools suggest glucose intolerance. Foul-smelling, greasy, bulky stools suggest fat malabsorption. Let's not skip over this, guys. Matter of fact, let me do the fat malabsorption, glucose intolerance. Give me 1 second. I had the blue. There we go. Let's not gloss over this. So if that stool is watery and explosive, you should be thinking glucose intolerance. If it's foul smelling, greasy, bulky, you should be thinking what? Fat malabsorption. They're not absorbing the fat, and so that's why we're seeing it in the stool. Diarrhea that develops after the introduction of cow's milk, fruits, or cereal might be related to enzyme deficiency or protein intolerance that's found in those foods. Neutrophils or RBCs in the stool indicate bacterial gastroenteritis or irritable bowel disease. The presence of eosinophils suggests protein intolerance or parasitic infection. Regardless, look at what it says, guys. Stool culture should be performed only when blood, mucus, or polyphenuclear leukocytes are present in the stool. Remember what I taught you about that word only, or always, or never. Pay attention. The hemoglobin, hematocrit, creatinine, and BUN levels are usually what? Elevated in acute diarrhea. It makes sense, guys. Do you remember seeing this somewhere else? Of course you did, because I wrote it in my handwriting. When did we see this in dehydration? It makes sense because if a patient has severe or excessive diarrhea, don't you think they're going to be dehydrated? Yeah. So we're going to see that H&H go up. We're going to see that BUN go up, right? We're going to see that creatinine go up. And if it's bad enough, we're going to see that urine output do what? Go down. All right. Anyway. So the hemoglobin, hematocrit, creatinine, BUN levels are usually elevated in acute diarrhea and should normalize with rehydration. So once that patient's rehydrated, we should see them go back to normal. Therapeutic management, again, oral rehydration, we always want to go from least invasive to most invasive. So if that patient's awake, they're alert, we're going to give them oral rehydration. And hopefully that does the trick. Give a child who's vomiting and oral rehydration frequent intervals and in small amounts. So even though they're vomiting, that's not a reason to not give them oral rehydration. You have to still keep trying, but you want to do small amounts because large amounts will actually make them more nauseous. All right, nursing alert. This is very important. Things to avoid. Look at what it says. Encourage intake of clear fluids by mouth, such as fruit juices, carbonated soft drinks, and gelatin. Encouraging this, look, does not help diarrhea. So these are actually fluids that you want them to stay away from. Why? They have a high carb content. Clear fluids such as fruit juices, carbonated soft drinks, and gelatin. Avoid them. They have high carb content and they really don't help resolve the issue. Avoid caffeinated beverages. Chicken or beef broth is not given because it contains a lot of what? Sodium. Let me tell you guys something. Anything that comes in a can, anything that is boxed, anything that is frozen, it's going to be high in sodium. So we stay away from chicken or beef broth. A brat diet, look at this. Remember the brat, B-R-A-T, bananas, rice, applesauce, toast? A brat diet is contraindicated for the child and especially for the infant with acute diarrhea because this diet has little nutritional value, low energy, low protein, and is high in carb, and it's low in electrolytes. So all of these are things to avoid. That looks like a select all that applies to me. Let's keep going. Infants who are breastfeeding should continue to do so. You know we love breastfeeding. You know how good that is for the infant, right? We're going to encourage them to continue breastfeeding, or oral rehydration therapy should be used to replace ongoing losses in the infants. Formula-fed infants should resume formula. The point is getting fluids in their body. In toddlers, there's no contraindication to continuing soft or pureed foods. Antiemetic agents are usually not needed. However, ondansetron, that's your Zofran, guys, this has few side effects and it may be administered if vomiting persists and interferes with the oral rehydration therapy. This is very interesting. As students, when you guys are studying, you just read the book, you're just reading. Pay attention. Why did they use this word? So we're going to give the Zofran because the side effects are few, but look what it says. It says that we're going to give it if the vomiting persists and interferes with oral rehydration therapy. That word persist let us know that even after we've done what evidence-based practice has shown us to do to resolve the issue, but it hasn't been resolved. Oh, the lights turned off. Give me a second, guys. 1 second. Okay. Sorry about that. So evidence-based practice has shown us to do is supposed to work. And if it doesn't work, that means it's persisting. When you're studying, you see that word persistent, go back. Make sure you understand what they're saying to you. So we're going to give Zofran if our nursing interventions and our medical interventions have not worked, they're still vomiting and it's interfering with the oral rehydration therapy. The use of antibiotic therapy in children with acute gastroenteritis, it's controversial. We really haven't seen that it works much. Look what it says. Most bacterial diarrheas are what? Self-limiting. And the diarrhea often resolves before the causative organism can be determined. Think about it. Remember, in order for us to find out what that causative organism is, what do we have to do? A culture. Doesn't a culture take a couple days for it to grow, for us to figure out what is actually growing, for us to know what the patient will be sensitive to? Yes. By the time we get that information, it's usually resolved. That's what they're saying. Antibiotics may prolong the carrier period for bacteria. And I talked to you guys about that earlier, so just make sure you know this. Nursing management. Teach caregivers to monitor for signs and symptoms of dehydration, especially the number of wet diapers or voidings. What does that tell us? Kidney function. I already explained to you guys how important kidney function is to fluid status. Okay, so let's look at the top. All right, so you're going to teach the caregivers to monitor for signs and symptoms of dehydration and the amount of fluids taken by mouth to assess the frequency and amount of stool losses. Education relating to oral rehydration therapy, including the administration of maintenance fluids and replacement of ongoing losses, is also important to measure, guys. Oral replacement therapy should be administered in small quantities at frequent intervals. If you give them too much fluids at once, it's going to make them nauseous and just vomit. Vomiting is not a contraindication to oral, I can't speak, ORT unless it's severe. Even if they're vomiting, you're still going to offer fluids, except in smaller amounts, but you're still going to offer fluids and do it frequently. If the child with acute diarrhea and dehydration is hospitalized, the nurse must obtain an accurate weight and monitor and carefully monitor the INO. The child can be placed on parenteral fluid therapy with NPO for 12 to 48 hours. Monitoring the IV infusion is an important nursing function. You have to make sure you're keeping track. Remember, these are little bodies that we're dealing with. You have to make sure that you're keeping track of what's going in and what's coming out, how much is going in and how much is coming out. Because remember, weight is our primary indicator of the patient's fluid status, right? But we also check other things. We check their INO, we check the skin turgor, we check to see if they have sunken fontanelles, we check to see if they have sunken eyes, we check capillary refill. Accurate measurement of output is essential to determine whether renal blood flow is enough to permit the addition of potassium to the IV fluids. Because let me tell you something, if those kidneys are not functioning properly, you are not going to be administering or adding potassium to the IV fluids. Because remember, guys, potassium has a very narrow therapeutic range and it can kill a patient like that. So it's very important to make sure those kidneys are functioning properly. Use a clean tongue depressor to obtain specimens for laboratory examination or as an applicator for transfer to a culture medium. If you have to draw a culture, if you have to get stool to grow a culture. Transport stool specimens to the laboratory in appropriate containers and media. Extra care is necessary to protect the skin from diaper region, from excoriation. The stool, the urine, guess what it'll start to do on the skin? Break it down. So you have to protect the skin from that feces, okay? Avoid taking temperatures rectally. You don't want to stimulate that area, guys. The patient already has diarrhea. You want to stimulate that area to make it even worse? No. And when I say make it worse, guys, I mean just increase. If you stimulate that area, you're going to increase the passage of stool. You want to do proper hand washing, make sure you dispose of soiled diapers appropriately. Also dispose soiled clothes and bed linen appropriately. Discard soiled diapers and linen in receptacles close to the bedside. Prevention. The best intervention for diarrhea is prevention. Guys, you know, we'd rather prevent than have to treat. Let's look at this nursing alert. To reduce the risk of bacteria transmitted via food, you're going to encourage your parents to do the following. Quickly freeze or refrigerate all ground meat, because you let that meat sit there, guess what grows? Bacteria. And that bacteria can cause the patient to what? Have diarrhea. Never thaw food on the counter or let it sit out for the reason I just said to you. Wash hands, utensils, and work area with hot soapy water. We want to kill any pathogens. Check the ground meat with a fork to make sure that it's cooked and it's not pink. And you want to cook all dishes made with ground meat until they're brown or gray inside. You want to make sure it's cooked completely. Meticulous attention to the perianal hygiene, disposal of soiled diapers, proper hand washing, and isolation of infected persons is very important in prevention of diarrhea. The best measure during travel to areas where the water may be contaminated is to allow the children to drink only bottled water and carbonated beverages. Look at that word only. Okay. Avoid tap water, ice, unpasteurized dairy products, raw vegetables, unpeeled fruits, meat, and seafood. The key word there is avoid. I've been ramming that word down your throat. You guys know when you see it, you know whatever comes behind it is important to know, right? Yes. Vaccines to protect children from some diarrhea-related diseases. The rotavirus vaccine is one of them. Make sure you know that. And guys, that is your dehydration and diarrhea in a nutshell. Please let me know what you guys thought about this video. Let me know what you guys would like to see me cover next or even more extensively. Don't forget, almost daily, you guys can find me covering different topics, different concepts of nursing on my other social media platforms, such as TikTok, Instagram, and Facebook. And don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. Guys, thank you so much for watching this video, and you guys will catch me on the next video.